What a great session this morning.
Hi, Lauren. Absolutely. I think it was a great session and a nice glimpse into what is yet to come. I think that we had really cutting-edge science presented and potentially studies that have the potential to change practice. What do you think about what was presented?
Yeah, they were all positive,
Yeah.
right? Which I think is so refreshing.
Yes.
We've learned so much about clinical trial design, preclinical trial design, the importance of longitudinal follow-up in patients in stroke AF, and so it was nice to see really impressive data that are informative.
And let me just start by mentioning SPAN, which you won't mention because you won't want to tout your own horn, but I will tout your horn. A great presentation and the results of a remarkable effort with, as you said, positive results. It was a fruitful exercise, a monumental effort, and we have some directions for where to go in the future. Not only identifying a compound that is worthy of testing in humans in conjunction with reperfusion, but also a roadmap for testing more neuroprotectant approaches. So congratulations again. And we have a separate interview related to SPAN, so we won't go that much into details.
Yeah, absolutely. Yeah, well, SPAN, as you know, and we talk about in the other interview, was a big collective effort, right? This was a preclinical trial with a coordinating center led by Pat Leiden, strong partnership with NINDS, and then 6 additional experimental labs. And over 3 years, we conducted a multi-site preclinical trial. And the results showed that uric acid passed the efficacy boundary.
Yeah.
And so we'll talk more about SPAN in depth in the Friday session at 9:15, ballroom D12. But let's talk more about stroke AF and APTOL, the 2 other major trials at the plenary.
Yeah, I think if we can just segue into APTOL, because it is a neuroprotectant.
Yes.
And what was it was exciting for me is that we're kind of getting the sense that there may be we should be cautious because we don't have phase 3 trials yet, but that we may be at on the cusp of some significant breakthroughs in making our patients better, not only through reperfusion, but sort of augmenting the effect of reperfusion, and maybe beyond, maybe also in patients who did not receive reperfusion therapy with neuroprotectant approaches. Of course, the low-hanging fruit for a neuroprotectant approach is going to be the thrombectomy patient that mirrors what is being studied in the animal lab, where you have a reversible model of MCA occlusion. And here we have a positive trial. It's a phase 2, so we have to be careful and cautious, but still some very, very promising results that mirror the basic science, the animal experiments that were done. And all the results are consistent in that not only the clinical results are better, but that also is paralleled by lower infarct volume, and is also a dose-dependent fashion. So it fits very well. It is exciting. Of course, we need a phase 3 to confirm. We know that in the past, the literature does have examples of phase 2 trials that turned out to be negative, but of course we all hope, and we have good reasons to hope that won't be the case.
Yeah, and I think TLR4, toll-like receptor 4, is a fantastic target. I mean, it's a central receptor that mediates the early inflammatory response. There have been many labs that have shown that TLR4 is important in post-stroke inflammation. And so here's a therapy that targets that. Again, given in an early phase clinical trial with thrombectomy, with reperfusion. And, it's early phase, as you said. There's primarily safety outcomes where they did show a reduction in mortality, and some interesting secondary signals that maybe infarct volume was reduced in the 0.2 milligram dose, and NIH stroke scale at 72 hours seemed to be reduced. And then there was a shift towards better outcomes at 90 days. So I'm excited about that moving to a phase 3 trial. I think that's really compelling, and I think inflammatory targets have a lot of promise.
Yes, and as you said, it's so refreshing to see positive studies. Even they may not be definitive, but at least to see positive signals
Indeed,
is a good place to be. And so we can move on to the atrial fibrillation detection.
Right, the 3-year results from
yes.
Stroke AF. So this was the study that was looking at the implantable link monitor. The primary results had been 12 months, but now they're presenting the 3-year follow-up data. What did you think?
Look, I think that to me as a clinician, actually these results are even more relevant than the 12 months, right?
Yeah.
And the lesson that I took from this presentation is that occult atrial fibrillation is even more prevalent than we thought. It's the AFib burden is significant, and so it doesn't seem that there's a limit to how much we should be monitoring. Maybe we should keep going even longer, but the big question in my mind is, especially given the fact that all these ESUS trials have been negative, that even though the prevalence of AFib is so high, maybe some of these patients, probably related to their AFib burden, may not benefit from anticoagulation. I think that's the million-dollar question. Where should we actually change treatment?
That's a hard one. I think what the 3-year results showed us is that the longer we monitor, the more AFib we pick up, right? So now it's at something like 22% of our patients that we didn't know, had AFib, end up having it detected. And that 2/3 of them, it was more than an hour of AFib. So these aren't little blips or things that you worry that maybe is artifact or something, but it's clinically meaningful. And so I agree with you. I wonder, how long do we monitor? Do we monitor everyone? Do we, because I often clinically still am a little bit selective of, do I have an inkling that they may have AFib, and then I'll monitor, usually first by surface and then by implantable. But this really changes what we do, right? And it really puts the burden on us, right, to search for the AFib in our patients.
I would like to see randomized trials of anticoagulation in this particular patient population. It's going to be very challenging because you first have to enroll someone, or you have to monitor someone for some time to detect the AFib, and then enroll them in a randomized trial where the standard right now is anticoagulation. But it's not clear to me that everybody should be
anticoagulated. Yeah. That would be a hard sell. I'd have to think carefully about that. In a stroke patient who we found AFib, whether I would, whether the field would have equipoise to randomize.
Maybe that there may not be equipoise, and people are just going to be DOACed, and that's it.
Yep.
But very thought-provocative, and I would say it's going to change practice, these findings.
Yeah.
I think also perhaps the threshold to go to long-term monitoring is going to be lower. Yeah.
I agree. Well, fantastic. So nice talking with you, Tudor.
Likewise.
Have a great afternoon.
See you tomorrow.
See you tomorrow.
Bye.